Pleasure being here with you. I'm gonna share a little bit of the new trend partially new trend in treating male incontinence with some slings and some balloons. So, as you've heard, we know a lot about incontinence. We know that we haven't improved really since Walsh's work and since that thing that Flavio just presented us. The new technology was actually booming in cases of incontinence in the very first 10 years since the robot was increased. There is a parallel increase in the incidence of incontinence cases. And actually this hasn't improved after the introduction of the robot. And I just reviewed the literature. It's a very interesting study published out of the Swedish group. There is actually no difference. If you want to do your radical prostatectomy with a robot or without the robot, laparoscopically or openly, open or robotic are actually the same. So that's something that we have to keep in mind when we are doing our procedures. So what is the guidelines? What are the guidelines saying? This is the level of recommendation when considering sling for treatment of post-prostatectomy incontinence. And I actually invite all of you to come tomorrow to the round table on this topic, where we are going to have, again, same structure as this workshop. And I think this is one of the strengths of this workshop. When you have a physical therapist, we have a urologist talking, a basic scientist doing, Flavio was actually acting as a basic science. We may be missing a nurse, and we should actually think about this in the near future. So slings are not new. Slings has been used since very beginning of 20th century. But the modern slings are all have in common the idea, and this is stolen from Vax, he's laughing on his own slide. Actually, I acknowledge you here, so it's legal. What we are trying to do is we try to increase the compression, in other words, the coaptation that is obtained into the proximal urethra, into the urethra at the level of the sphincter, whatever this is, if it's still preserved there. I personally, I have to admit, I do not believe in any theory of repositioning or excessive mobility on the urethra as being cause of male incontinence. Now, the slings that are nowadays available can be divided in two major categories. One is are the non-adjustable. You place the sling, you obtain the results that you want to obtain, or you hope to obtain, or the adjustable slings. You place the sling, you can either try to adjust to obtain the result right after the surgery, or you try to obtain this the next couple of days after the surgery. But the advantage being that you can try to do this fine-tuning on the continence also months or years after the surgery. And I'm going to just give you, I have personal experience with some of them, but I'm just going to give you what the literature is saying. The non-adjustable sling, they have the difference based on how they are anchored onto the body, patient's body, and the holes that we are using to place them. So the first one was this, using very small screws to attach the sling onto the periosteum of the pubis. I'm going to show you this in detail. You can go through the obturator foramen. This is, again, taking the idea of treating female incontinence, using the obturator foramen for male incontinence as well, or a combination of the two, using something that tries to attach the sling onto somewhere into the area in front of the pubis and use the obturator foramen. So those are the names. The bulbourethral sling, I can just go very fastly through this. The reason why I'm still bringing it up, because I have the complication rates on here, and I think it's important to remember that we abandoned a lot of these slings because of lack of effect and because of a huge complication. Again, if you project yourself in a car seller, it would be really, really tough to sell a product that has 50, 60% of chance that your car is going to work, and 18% of chance that you are going to have severe pain driving this car. So the same thing is in practicing medicine. This bone anchor main sling, great idea. You have a small piece of mesh. You try to anchor it onto the periosteum of the pubis. The problem is that they're not working as they should. It's very easy to make these nice drawings. It's very easy to deploy these anchors, but the problem is that those anchors are just not staying as where they should stay. And as Vax mentioned, I was very involved in the around 10 years ago in placing balloons. The majority of our balloons placed, especially in the US at the beginning, were because of the failed bone anchor main slings. And what I was impressed, it was seeing those anchors dislodged from the periosteum of the pubis. So they were not there, and they were not. The support was actually completely gone. There are a lot of materials that you can use. Originally, they designed polypropylene, which is, I believe, a good material. It's actually pretty safe to use it onto the male urethra. It's safe also on the female urethra. You just have to know how to do it. They try, this is from A.J. Singler, try to use other materials like pure biological material. Sounds very greenish. Green is very popular nowadays, no? But it's just not working because they all get reabsorbed. So that's why he was combining this, so have something biological with something that stays, and actually the only thing that was really working was probably the polypropylene portion of it. Success rate, again, it's kind of okay, 66%. You should discuss this with your patient. If you tell him that he does not want to manipulate himself each time that he urinates, in other words, if he does not want to use an artificial sphincter, and he wants to improve his, using carefully the words improve and not being cured from your incontinence, it's a reasonable result. It's a reasonable thing, but you have also to discuss with the patients that this is not a procedure, like a minimal invasive procedure does not equal lack of complications. And again, the list of complications is very similar compared to the one before of the traditional slings. They were abandoned because of the pain. And I think that this was is one of the reasons why this happened to the bone anchors male slings. So they are no longer available. The idea to go through the obturator foramen is probably better because it requires more surgery, more preparation on the urethra. The key point, in my opinion, why a sling is working is because you mobilize the urethra, and this you obtain a hypermobility of the urethra, and it is 100% iatrogenic. It's during the procedure while you are placing the sling. You can decide if you want to mobilize it completely, or you can leave the muscles alone. You always have to mobilize the certain point from the central tendon of the perineum. If you don't do so, the patient will experience huge amount of pain, and there will be no result in your sling surgery. So, and I had long discussions with the friends who basically invented the transobturator sling. They were huge proponent of the idea of hypermobility of the urethra. And we were actually in the live surgery together. And the case where this advanced sling was placed was in after TURP. So I was being a bad guy and a teenager because I'm now 25, so I was significantly younger at that point. I asked the colleague how can he explain a hypermobility after TURP. The patient was incontinent before, and patient actually gained continence after the procedure. So I still need to be convinced that the hypermobility of the urethra has anything to do. It's done with very solid material, very widely studied, safe material to use underneath the urethra. And as you can see here, if you improve your technique, your surgical technique, you can obtain better results compared to the one with just bone anchors. You just expose the urethra and you try to compress. This is not working. If you combine the improvement and the cure rate, I think it's significantly better. But also here, it's actually interesting that you can cause retention. For me, this is a great thing. If I have a male patient that goes into retention after a sling that I place, and say, success. This is not going to last. Usually, within a couple of weeks, you're going to start to urinate, a max couple of weeks. Usually, this takes not more than 4, 5 days. No, I'm not aware of any case of a permanent retention after any main sling. Means that the male urethra and the female urethra are quite different, and it's not only the length that makes it different. Displacement was an issue with the very first design, so the 0.1 design of this device has been redesigned, has a much better grip, and that's why this is not a problem. But the pain is still there. So that's something that you have to counsel your patient whenever you're doing something for on their urethra. They may experience pain, and this pain can be prolonged. It's probably related with the infection or with the lack of mobilization of the urethra or with the combination of the two or some technical errors during the positioning. I just said this. The quadratic sling, great idea. So you have a combination of compression of the urethra and of the repositioning of the urethra. So both things that I do not believe, as I just disclosed. So you have the transobturator arms, and you have the prepubic arms. Again, I was actually involved in this, partially in the developing of this type of sling, and I had the first objection in. I asked my colleagues who were involved as well there, how is the prepubic fat, this is what we have in front of the male pubis, doing anything, what is doing anything on stabilizing this mesh in place. And we had like a very acrobatic procedures trying to fix this, and until we start tagging these prepubic arms onto the periosteum of the pubis, the results were not there. So again, we place the transobturated as the difference is that you go from inside out. Not really a big difference in a male. It's probably a little bit easier going inside out because you can go as cranial as possible, so as cephalic as possible in this. If you're too distal, you will not obtain this good compression effect onto the urethra. And here is the initial idea. There's actually this was designed by these 3 guys, Craig Comiter now in San Francisco, Eugene Rhee in San Diego, and Victor Nitti in New York. Great results at the beginning, but again, as you can see here, there were some problems with these pre-pubic anchors. They were not just staying there, and the reason is again, you can see here some side effects. Still, again, same thing. Pain is an issue with all the slings. And whenever I'm doing a sling on a male patient, I'm actually discussing the pain, the possibility of having a pain after the surgery. And this was just published in Urology a few months ago, stating again, with the old technique, the one without the fixation, as results are here. So out of 31 patients, majority of them were failures, so not a success. So the conclusion of the conclusion for the authors was that this is actually not a recommended procedure based on their results. And I agree. If I would have had the same results, I would not do this type of sling. Now, as I said before, I like to think out of the box. So I started doing my fixation differently from the very beginning, and my results are not like that. So my results are better, but this is very anecdotal. I have nothing published on this. So what you have to take home is what is currently published on the article, on the literature. We know that there is actually a new paper coming out of the European study, but it's not published yet. If we move now to the adjustable slings, again, idea is you place the sling. You can do the fine-tuning right during the surgery, right after the surgery, a few hours, 6, 12, 24 hours after the surgery, and then time after the procedure. They all claim it's a great advantage. I agree, it's a great advantage that you can re-achieve the continence with the new. Let's say you develop apoptosis after a few years, and you go there and you just redo the tuning. The problem is that they all require additional surgery. And when I was trying to explain to the patient, look, we can do this. It's not a big deal. I just have to redo the incision. We're gonna readjust everything. They say, but doctor, you need to repeat the surgery. You need to repeat the procedure on me. So they are not really that happy. So one of the possible area of research is to actually be able to obtain this adjustability without surgery. So this is one of the example. Again, we always start with the best part of the universe. So we take the female Remax, which was the first one available, and then they adjust this, they put it onto the male. So it's a male version of a Remax. There were some issues in the very first, in the beginning of these procedures, because the male urethra requires a lot of tension, and actually this was actually eroding over the fascia of the rectus muscles, and now they have to redesign the way how this is held. But the results are very interesting. And results are in a non-selected patients, means that all the patients with incontinence, regardless of the severity, receive this, this type of procedure. This is in a group by one of the first author, Sousa, from Spain. You have from 40 to 80% of success rate. But again, with the now we start seeing more of complications, like severe complications, like urethral erosion. Usually we don't see erosion with the sling. And this is because of the lack of selectivity for the procedure. I don't agree with the strategy that you should apply your technique to to all the patients that you have. You should have multiple techniques for our patients. Their incontinence can be very, very different. This was published in European Urology with his results. They have one other issue is that you are entering blindly into the retropubic space. This is the issue with majority of these slings that require a retropubic positioning. And it's just a matter of a time when you're going to do the bladder perforation, which is not a big deal if you recognize it. And I remember my very first experience with this procedure was with a misdiagnosed bladder perforation that caused an osteitis of the pubis, and the patient was in the hospital for 6 months after the procedure. So you have to be very, very meticulous when you do this procedure. This is now longer follow-up with very interesting results with this adjustable device. Another one, Dr. Hubner is a big expert in this one. My only experience was when observing him doing this in Vienna, which is a very similar concept, but besides having this vari tensor, which is the piece of plastic that sits on top of your pubic bone, you have these columns specifically designed that can get basically attached by the washer. And you can do in two fashions this, retropubically or transobturatively. I don't think that there are studies showing which one is better based on the severity of the patient, but I would encourage the authors of this or whoever does this type of procedure to present the studies. This is what was published on the Remax. The very first one was Victor Romano from Argentina. He retired, but still very active academically. And the results were interesting again. So we are between 60 to 70% of the patients who are dry with this procedure. But again, you have erosion rate, which is way too high. It's probably because of lack of proper selection of the patients. If the patient has a radiation, a very bad incontinence, I really don't think that this should be the route to treat their incontinence. There's a combination of balloon and a sling. Atoms, so it's a balloon within the sling. You place this around the obturator. You inflate this. The results, again, interesting. Relatively short series of patients. Not many centers published a lot on this. They had some issues. Pain, again, is an important thing because the typical volume on with the patient is sitting is pretty high. It's around 10 to 12 cc's of water. So try to sit on a golf ball for like the whole day, and then let me know how would your pain be. So complications, of newer generation, severe complications are not as common as they were in the past for the sling. The bulbourethral sling had the highest incidence of complication. That's why we don't do them anymore. Perineal pain is still there, and we still need to fix this. And this is that's why it had the level of evidence 3 in using this type of procedure. Just 2 slides on balloons. I do not use them anymore because they're just were cleared by the FDA basically a few months ago, and there's still not a code in US for do them. The idea is to replace basically the prostate around the urethra, and you have the same type of compression as I saw you at the very beginning with a sling, trying to obtain this better coaptation of the mucosa done by these side balloons. The great thing is that you can reach the adjustability. This is the most easily adjustable device that I am aware of. You can just puncture this from outside. This is usually placed in the scrotum, so you can adjust the volume or increase or reduce the volume based on the patient needs. And this can be done, Dr. Huber and I, all generation, we are doing this under X-rays, but the new generation is actually doing the same thing under the ultrasound guidance. And you can see here the urethra and a nice coaptation of the urethra. You will say all these patients should be dry because you can see exactly where you're placing. The balloons are staying exactly where you want them to stay. There will be no complication. The result is actually a little bit different. We have a pretty high explantation rate for these devices because at the beginning we were not selecting properly our patients. This is not a device where you should use in irradiated patient, and the majority of the explanation rate was due to the previous radiation treatment after the radical prostatectomy. Success rate reasonable, very similar to the one obtained with the slings. This is from our two general secretaries ago, saying that male slings, and I will add the balloons as well, are a valid option for treating male stress incontinence. They do have some advantages. However, we are still not having the same results as we have with the old-fashioned, the good old-fashioned artificial urinary sphincter with like 20 years follow-up data. We know everything, what can go wrong, when can go wrong, and how to fix when this goes wrong. What we need to obtain with any procedure we are doing in our patients, and this is, I'm putting this because this is, in my mind, the most important evaluation beside the 24-hour pathway test, is to obtain a coaptation of the urethra. If you cannot obtain the coaptation of the urethra with your procedures before doing your surgery, means that your urethra is messed up, and you shouldn't be doing anything else but circumferential compression. This is my very last slide, summarizing it. You have a mild incontinence, and you can argue what this is, can be like less than 400 grams on the 24-hour pathway test. But basically, if you can obtain this nice coaptation of the urethra, so that the mucosal sealing can be there, these are all candidates for some alternatives to circumferential compression. And this is nothing else that you need to obtain a success rate in treating male incontinence if the patient has a bad urethra, severe incontinence. Thank you very much.